you know a little bit about myself, I have my doctorate in physical therapy. I've been at UF Health now about over 8 years. I have a specialty in neurology. I'm board certified in neurology, and then I have subspecialties in MS, stroke, and Parkinson's. I run with a team around here, a great team, that consists of neurologists and rehab specialists. So I'm going to be speaking today about one of our programs that we have. It's our UF Health Jacksonville Comprehensive Balance and Mobility Program, and I'm going to be speaking specifically about balance in relation to stroke today. Okay, if you guys have questions, please feel free to shout them out as we go. I'm going to keep this relatively informal, okay? And I also like to walk when I talk, so we'll see how this goes with the computer. So basically our rehab team consists of myself and 3 other therapists over in the Pavilion building across the street. We also have our neurology team headed by Dr. Schneider. She's one of our movement disorders physicians, and she works closely with the other neurologists over there, like Dr. Crooks and Dr. Silliman, for example, to make sure that we're doing a comprehensive look at what can be causing underlying balance issues. We also have our ENT department, which consists of an audiologist as well as an ENT surgeon who looks at the inner ear. And I'm going to talk a little bit more about the role that the inner ear plays in balance today. And then we have a pharmacist that looks at medications, because a lot of our medications can actually lead to falls and in some cases prevent falling. So we have kind of a group approach to balance. So why is the balance program needed? Why did we decide to go ahead and build this program? The CDC did some research as far as incidence of falling, as well as the money amount that we were billing for falling. And in 2012 alone, the cost of falling was $30 billion. And that was just for Medicare. And that was just a result of falls. Okay, so huge numbers. They're expecting that number to go up in 2020 up to $67.7 billion. Okay, so huge amount of money that we're talking about. Hospital-related falls are often happening 5 times more than they are for falls in particular compared to all other injuries. So you're much more likely to be admitted for a fall-related incident than you are even for other conditions, including for stroke, which is kind of shocking, okay? In 2012, the emergency department treated 2.4 million non-fatal fall injuries among older adults only. So those numbers are astounding just for falling, right? Now, specific for stroke, they have found that up to 73% of people with a stroke fall during the first 6 months of being home. So a lot of times we think of falling in relation to, you know, you're getting tired or maybe an overtime type of a thing, something that might just occur. But this actually found that falling is also very indicative early on. So we want to make sure that we are addressing these things early as well as late in care. The other thing that happens with stroke is that we unfortunately do not have the bone density that we need to. Bone density actually goes down after a stroke, they have found with research. What this means is that your bones are not as strong as they should be. So now you're more prone to falling, and you have bones that are maybe not as strong as they should be, and that combination is not a great combination. Most commonly, it can lead to an increase in hip fractures. Okay, so you're actually 4 times more likely to have a hip fracture than you are if you had not had a stroke. Okay, so what they found to kind of battle this is that formal fall programs are recommended. And these fall programs are organized. They're very specific as far as what they look at and the treatment that they come up with for it. And they recommend that after you've had a stroke, you be assessed for falling at least once a year to maintain, just to make sure that you're not at a risk for falls, or if you are, to go ahead and get into a treatment program. So kind of think of it like you go to the doctor for your physical yearly, you should also be being assessed for falling at that time too. Okay? So how do we keep from falling? So what makes you keep your balance? There's 2 main systems that lead into your balance. One is postural control, which is basically you utilizing your muscles in your core to maintain your balance over your feet, okay? And then we have gaze stability, which is utilizing your vision and your inner ear, which I'm going to talk about, to be able to maintain that balance. It's what tells your brain where you are in space. So when you go to move, your brain knows which muscles it needs to activate, okay? So these 2 systems are what we look at when we're looking at what's involved in your balance. The biggest one we're going to talk about is this first one, postural control. And this is a really busy slide, but what that means is there's a lot that goes into postural control. Okay, you have to use your sensory systems, your motor control, and I'm going to talk about some of the big ones. So this is Christina. She's one of our therapists across the street, and she is currently trying to maintain her balance on a little foam pad that challenges her balance. So when we first look at her balance, for example, she's standing in an environment that maybe is a little challenging for maintaining your balance. What does your body have to do in order to maintain that? So there's three main sensory systems that let you balance, okay? You use your vision, you use your feeling in your feet, which is called somatosensation, and you use your inner ear, which is this tiny little organ. You have one on each ear, and it sends signals to your vision and to your brain to tell you where you are when you're standing, okay? So these are your three main sensory systems. Now the normal pattern, so if I go to balance on one leg, for example, my body is gonna use my vision first to give me feedback. Then it's gonna feel my foot, okay, so I can get feedback of where I'm standing. And then last resort, my inner ear is gonna kick in and give me some feedback. That's normal, that's how we develop over time. Everybody develops like that. What happens though is when there's an incident, so an injury to an organ or a system, like a stroke, for example, maybe it affects your vision, maybe it affects your feeling in your feet, you have some numbness, maybe it affects your inner ear. When those systems are affected, your body is automatically going to try to utilize those three systems in the same pattern you utilized it for your entire life. And that system pattern is not always the best for you to utilize now because those systems are not optimal, okay? So what this can lead to is instability and falling. If you're trying to use a system that's not correct, it gives you incorrect feedback, it can lead to a fall, okay? They found that in particular, whenever you have a sensory system that is involved and you also have a motor system that's involved, it can lead to an increased incidence of falling. And unfortunately, a lot of times with stroke, we see both sensory and motor systems that can be involved, okay? Now, how do we determine which of your systems are involved? There's me. So we're doing some assessments on our neurocom system, which I'm going to tell you guys about, and it's going to give us some great information on which systems are involved. So when we first see you in therapy, anybody that's been to therapy, you know we ask you a whole bunch of questions, right? Or we should be asking you a whole bunch of questions. How about that? So we're going to ask you about your home life, what you're having trouble with, all kinds of things, okay? And then we get into a whole lot of testing, all right? So we're looking at your range of motion, we're looking at your strength, your sensation, your reflexes, tone, all kinds of things. All of this is typically done in either a seated or a laying down position, right? But we're not looking at balance necessarily. So the way that we do that is we put you in a harness, and you can kind of see the harness up there, and we look at your different balance systems. So you're in a safe environment, and we can look at really how you react to different areas moving, maybe the environment moving, or maybe your feet moving. And we can look at that. So I'm going to show you guys a little video. So as you can see the wall moving. So there's different challenges that we can actually put into this system that can give us different feedback as far as which items are working in your inner ear, your vision, and your somatosensation. So that force plate under his feet actually moves. You see he's being challenged. That wall can move. We can set up different challenges basically for your balance. There we go. So it can tell us about each of the systems that you're utilizing. How do you perform in each of these areas that we challenged? It can also give us a fall risk assessment score, which is very important because it compares it to norms of your height and your age. So it will compare you to, it's thousands and thousands of people that they've documented in here. So one of the excuses I get is, it's not because I had a stroke, it's because I'm getting older that I'm falling, right? And I get that a lot. And this will actually compare it to what's normal for your age and your height, everybody between the age of 8 and 108. So that is no longer an excuse, okay? The other thing that it does is it will tell me what sensory systems you're utilizing, which ones you are trying to utilize, and which ones I can train, which is great, because then it'll tell me exactly where I need to go as far as rehab. Okay, very specific information. This is an example of somebody who has an issue with their inner ear. If you can see up here, it'll tell me how they're doing as far as trials go, but it'll also tell me how well they're utilizing that inner ear system down here. Another test that we do as far as reflexes go are looking at your automatic reflexes. So what we want to be able to see is how well, if you step onto a different surface, so let's say you go outside and you step on the grass, how well is your system able to adapt to that change in surface, okay? And we do an ADT test that looks at that. And if you look at the floor,
quickly, starting now,
it'll tilt. And so we can see how well you're able to maintain your balance.
The platform's gonna rotate.
And keep from falling, which is great. Again, you're in the harness system, but we can really see how you do with it. It also gives us a lot of information. It tells me how much weight you're putting on one leg versus the other, which, as we all know with stroke, that is very important because we tend to not put weight through the leg that's involved. It will tell me how well and how quickly that impulse actually kicks in. So are you delayed in the reaction time it takes in order for you to maintain your balance? When we're doing your sitting strength testing, you might be nice and strong in different muscle groups, but how fast are you actually incorporating that strength is also extremely important. And this is an example of that test. And then the last test that we're doing, looking at the motor control test. So this is a forward and backward testing, very similar to the up and down, but it gives us more information as far as your reflexes go. I'll show you guys that one. So if you watch the force plate again,
starting now,
it shifts either backwards or forwards and challenges your balance in that manner too. So again, we get lots of information on which system we need to utilize. It also gives us information on how much a muscle is actually kicking in. So if you can see down here on the bottom, right here, this is you just standing, this is movement in the force plate, and this is how much your muscle is actually kicking in. So this is a normal test, patient's just standing, normal, no problems, muscle's not working. Then you have a big motion, which is normal, and then you go back to resting. A lot of times what we see with stroke is we see movement initially, so you're already trying to maintain your balance. Then we have a huge motion, because that motion kicks in, or we don't have any motion at all, and then a fall. So it gives us a ton of information on what you're actually doing when you're balancing. The other thing that we look at is strength. So how well are you able to move, even if your feet are planted? If you had to lean forward to reach something, how well are you able to do that? This test, unfortunately, I don't have a video for, but basically what you do is you stand in that box and you shift towards different targets, and it looks at how well your muscles are able to do that. So here it tells me which muscle group you can utilize, okay? It also tells me where you're keeping your weight. Here's an example of that little spider graph up there. Is how well and how far you're actually able to move in each direction. It'll tell me your reaction time and physically how far you're able to move compared to norms, again, for your age and your height. Okay. The other thing we want to look at is how well you're able to function. So this is all you just standing and trying to balance. We also want to see how you do when you're performing different tasks. So there's various tasks that we perform in clinic. One is just walking, of course, right? We need to look at how you're walking. So we have a platform that you walk across. It's about 10 feet long. And we look at different things with the walking. We look at how much sway you have, how long of a step you're taking, how wide your steps are, how fast you're walking, and then how much weight, again, you're putting on one leg versus the other when you're ambulating. So we can really work on different aspects of your walking instead of just generic balance and strength testing. If you're high level, so a lot of times I'm doing really good, I just have a little bit of a balance problem, but not bad, okay? We also have testing that looks at how do you walk with one foot in front of the other, okay? How do you squat? When you go to get up from a chair, are you putting all of your weight on one leg, or are you utilizing both legs? If you had to lunge, so if you had to pick something up off the floor, were you able to do that with weight on either leg? What's your reaction time and how much weight are you putting through those legs? So a lot of specific information that can really help us out when we're trying to figure out where we're going with your treatment. And then that other portion I talked about in the beginning is your gaze stability. So how can you use your vision and your inner ear to maintain your balance? And we have two tests that also look at those things by having you move your head and try to basically read. Everybody loves those eye diagrams, right? So you have to read one of those as you're moving your head, and it gives us a lot of information on that as well. Now, neurocom, so this system has been shown effective for individuals after stroke, but particularly in order to show where we should go with rehab. So showing what type of therapy you should be having as part of your exercise program. It has also been shown to correlate to other commonly used tests, which is nice because a lot of times we can go back and kind of look at how you were doing before compared to what you're doing when you come into clinic. I mentioned one excuse that I get all the time is it's just because I'm getting older. It's not because of the stroke. I'm not a fall risk, right? The other one that I get is, oh, it was just one fall. I don't actually fall a lot. I'm not at more risk for falling. It was just a freak thing that happened, right? So the other thing that the neurocom looks at is it actually has a correlation to if you are a one-time faller, if it was just that you tripped over something, stuff happens, or if it's actually that you are more prone to falling, and we do need to work on that. So again, that's kind of another excuse that we can throw out a little bit, okay? Now the big question I get is, okay, I know I'm gonna fall. I know I'm a fall risk. You guys keep telling me this. What do we do, okay? So there's lots of different areas we can work on in therapy. One is walking. I mentioned that before. A lot of times we work on overall mechanics, speed, equal weight bearing, those types of things. We work on safety, we work on strength, and we work on training those sensory systems that I mentioned before. How do we do that? There's lots of different interventions. It really depends on what your testing reveals, the way that we go with the training. But I wanted to mention a few that maybe people aren't so aware of. One is postural training. So we actually work on maintaining core strength, stomach strength, back strength. In order to maintain your balance. A lot of times we get consumed with the leg and we don't necessarily think about the stomach muscles that have been affected as well, so we need to work on that. Task-oriented training with sensory manipulation, so that is an example of that wall moving in the background. You might do great if you're just standing at your sink, but if you go outside, if there's cars going by you, maybe that's when you start to have difficulty, and that's what we work on training. We train the inner ear. We work on something called functional electrical stimulation, where if you have weakness in your muscles, we actually stimulate those muscles to try to get them back to where they're supposed to be. I'm almost done. We work on balance training, walking training, all kinds of different training. So I wanted to show you guys some examples of my patients that I've treated so you can kind of see how they did before and after the program. This first one, this is not the lady, this is just a picture of what we did, but this is a patient who had had a stroke about 6 months prior to coming to see me. And what we did is we went ahead and looked at her walking. She was utilizing a cane, a single point cane to walk. This one on your guys' left is when she first came in. So you can see her step length was 32.9 centimeters. We like that number to be close to 60 for normal. So it's considerably a small, short little step. And then after a month of therapy, we did, and why I put a picture of that, we did a lot of body weight supported treadmill training with her. So we did a lot of walking over the treadmill and kind of manipulating mechanics. She increased her step length to 49.9 centimeters and did not have any falling the last 3 weeks of therapy. So that was only after a month. She made a huge improvement. You can also see here, here's her little short, little stocky steps. And this was her after, okay? So that's only after 10 feet. This is not distance, but at least you can definitely see a difference in her. And she got rid of the cane. I didn't say that either, which is nice. So it took her 5 steps to go 10 feet in the beginning. At the end, it only took her 3 to go to the same distance, which is huge for energy conservation too. This was another patient that I had. Now, he was interesting because he had been had a stroke 3 years prior to coming to see me. So he had been in and out of therapy several times, okay? He was kind of, nothing's gonna help, this is how it is, and his family members kind of pushed him to go back to therapy, okay? So this was his walking when he first came in. He was using a quad cane, and this is not him again, but this is a good example of how he was putting a ton of weight through that quad cane and really not utilizing the other leg so much to walk, okay? So this was him when he first started. I ended up keeping him for 6 months. So I kept him for quite a while because he kept progressing and progressing and progressing. When he first started coming, he was putting 72% more weight on one leg than the other. That's basically like walking on one foot, okay? By the end, he was only putting 17%. difference between the two limbs, okay? Again, you can see how many steps he had to take, 12 steps to go just 10 feet, okay? If you think about 10 feet, it's basically from here to the end of that second little pole there. It is not a long distance, and he was stepping 12 times to go that distance. That's huge energy to go a small distance. At the end, he was only having to do 6, okay? So he was able to cut it in half. We did with him, and he was able to maintain his balance much more equally. Like I said, 72 to 17%, huge difference. So a lot of times we can work on those types of mechanics as well. And then the last one I wanted to show you, this was an individual who had had a stroke about a year prior to seeing me. They were ambulatory without an assistive device, but they kept feeling kind of off kilter. They'd have trouble outside, for example, if they went on grass or gravel, that kind of thing. They utilized an AFO, so a brace on one ankle, and he wanted to see if he would be able to kind of improve that dynamic stability where he was at. So we did the neurocom testing on him, and he had a lot of difficulty on conditions 5 and 6. When I only kept him for about 6 weeks, okay? After I retested him in 6 weeks, he had improved all of those scores to above normal, which is great. I actually ran into his wife at Publix about 6 months later, and I asked how he was doing, and she said, great, no falls. He's actually getting rid of the cane, he's doing, or the brace, he's doing great. I said, I would like to see, just curious, if he could come back and I could retest him to see what his scores were, because I was curious, you know. So he came back in May, and I redid the testing, and again, everything was within normal. So even though I wasn't physically seeing him, he was keeping up with his homework, and those scores actually maintained, which is fantastic because that's what we want to happen. So his fall risk when he first came in was 13%. So he was a 13% fall risk for his age and his height. After a month, he was within normal, and 6 months later, he was still within normal, which is of course what we want to see. No more falling, okay? The other thing it showed us is he was having difficulty with his inner ear. So even though he had had a stroke, that system had been affected. Nobody had really looked at that system. So we caught it with this test and we were able to improve it. You can see the improvement there. On the first one, he barely even showed up, that tiny little graph. And then he was able to improve it. And the interesting thing was, even though I wasn't seeing him, he kept doing his homework, and you can see that graph continued to go up, which is fantastic. Okay, so yeah. So we gave him specifically exercises to work on. Basically what you do is you keep your eyes fixed on a target and you move your head in various directions. You do different backgrounds, those kind of things. You do it standing on a surface that is also challenging. So you take away those other senses and you make them use their inner ear. So you can kind of train it up, basically. A lot of eyes closed activities, those kind of things.
So he didn't need to go to an
ear, nose, and throat? Nope. So we have our balance program set up to where, if he had a lesion or something where I had to have him go, if we did not show improvement within 4 weeks, then we would send him. But he had improved so dramatically that he was good to go. Yes, ma'am. Good question. Mm-hmm. The other thing that it showed, we did not work on his strength whatsoever. All we did is vestibular inner ear exercises. Okay. When he first came in, here on that middle graph here, this tells me which system, which ankle strategy, hip strategy, which muscle group you're utilizing for your balance. When it's within this cone, that's utilizing your ankles, which is normal. That's what we want to see. So we want to see all those little shapes in that cone. Initially, he had a few that were outside, which means he was trying to use his bigger muscle groups, his hips, his glutes, those kind of things to maintain his balance. Even though we didn't work on his strength, by a month later, he only had one incidence where he was not utilizing his ankles. So trying to get that sensory system better affected the motor system, even though we weren't specifically utilizing that motor system. And then when I had him come back, everything was in that cone. Even though, again, he wasn't doing exercises specific for motor, we were just doing the inner ear stuff, which just relates to, we really have to look at those systems. Leg strength is great, but if we're not affecting those sensory systems, it's not going to make a long-term difference. You're still going to have difficulty. So really important to look at those systems as well. Okay. So kind of conclusion-wise, falls and prevention, especially in individuals with stroke, is extremely important. We know the incidence is higher. We know you're at a higher risk for fracture. We want to make sure that we're preventing this as best as we can. We here do a comprehensive assessment of that and try to get you specific exercises to make sure we're leading you in the right direction, not just giving you, generic things to work on. I wanted to kind of include, if you're looking at outpatient rehab, regardless of where you go, there's kind of a couple things that you need to know as far as Florida and reimbursement goes. Florida currently requires you to have a prescription for any outpatient services rendered. So occupational therapy, physical therapy, speech therapy, you have to have a script from the physician that states that it's basically medically necessary in order for your insurance to pick it up. That also goes for any assistive devices, braces that you might need, even modifications to braces, you have to get a script. So just to let you know, if something happens to like an assistive device or something like that, just be aware if it's a little bit of a process in Florida to get something fixed. The other thing I wanted to mention, because a lot of people have Medicare, as of 2017, outpatient services are capped annually. For occupational therapy, they have $1,980 that they can utilize. It's not dollar for dollar. Medicare has like this weird equation that they kind of work off of, but it's from January through the next January. You can actually get an extension if your therapist's notes are real good. You can get an extension up to $3,700, but a lot of times that will not keep us through the year if you're going through therapy on a scheduled basis. So be aware of that. If you think you're going to have a different procedure, you plan your amount accordingly. If you know something's going to come up. Here at UF Health, we have 3 different offices. We have the Pavilion Building, which is where I spend half my life. we have the Emerson location, which is a couple exits down. They're actually going to be expanding to a pretty new office come November. And then we have our North Side campus now. So if you live more north side near the airport, they also have a location there as well. I have a ton of references. Any questions? That's for you. Oh, you shoulda. We're gonna be better this week. It's gonna be better. Yes, sir. Seizure, so there are different types of seizures, but there is such a thing as a stroke-related seizure or post-stroke seizure. Seizure, it cannot be affected, unfortunately, by rehab. There are certain things that we cannot do if you are on seizure medications, as far as you typically don't do electrical stimulation, those kind of things. But seizures are more modified by medication.
And how does that affect the inner ear?
It doesn't. Inner ear is a completely different system. It's its own little organ, so it sends signals to the brain, but it will not actually be affected by a seizure. Okay.
What about dizziness?
What about it?
Many of us might experience, and I remember the doctor saying at one time that it could be the crystal was out of position.
Correct, yeah. So the inner ear, the organ, has different canals that when you move your head in space, you have these little crystals. They're basically calcium deposits that they shift in your inner ear and they rub up against hair cells, and that's how your body knows which way you're moving. So sometimes, especially if there's some kind of trauma, like a car accident or a fall, for example, those little crystals can be out of place, and we can do different maneuvers to get them back in place. It will show up on our neurocom testing. We, of course, do other testing as well. But you can also have the nerve itself that goes from that inner ear to the brain or to the eye that can be affected. And that's more of the training that I was mentioning before with the gaze stabilization, trying to keep the eyes in place. So there's a couple of different things that can lead into that. Typically, the actual organ itself is not affected by the stroke. It's more of if there's like a blood flow issue or something like that prolonged over time. But the actual incident of stroke usually will not affect that organ.
Is there any way to prevent the dizziness that seems to come on unexpectedly, oftentimes like a stroke itself?
Sure. Unfortunately, no, is the short answer. The best that you can do is kind of heighten the other systems so that if you do have a dizzy episode, you're able to utilize those other systems better. But there is a surgery that will keep those crystals in place. Questionable how useful it is because they can still move after that. Mm-hmm. You're welcome. Any other questions? Okay, thank you guys.
Thank you very much.